Good afternoon, everyone. No, we're not sounding good. Good afternoon, everyone. Okay, that's it. Okay, so I am not Dr. Lee, I am Dale Maitland, and this is Dr. Alan Lee. So ETSN, I am the capacity building coordinator there. So I'll just go right into it. So this is the agenda of the areas we'll cover within the next 15 minutes. So stay tuned. So with the ETSN program, we found that these are some of the things that happen to newcomers who are HIV positive and racialized as well. So the structural barriers that they are facing is HIV stigma, homophobia, racism, sexism, xenophobia, and with that they have service access challenges, right? Like language, insurance, the visa status, and all, and it leads to the disruption of their HIV care. So a little history about ETSN. It was first piloted in 2003, and it was for need. It came out of a need for increased peer-based treatment and educational support for the smaller marginalized community that lacked the support. So we started with HIV treatment information. We did it in different languages, and that was between 2001 to 2003. The interest grew from community members, and we improved the treatment literacy and the peer support skills. And this is a framework of the earlier thing when we got started. If I'm going too fast, just tell me. So these are some of the persons that are a coalition of with us. As you can see, we have Black Cap, African in Partnership Against AIDS, Alliance of South Asian and AIDS Prevention, Asian Community AIDS Services, Center for Spanish-Speaking People, AIDS Bereavement and Resiliency Program, and CAAT. ETSN program planning. We are guided by an independent community advisory group. We have representatives from each member organization, and also we have on that committee persons living with HIV who have gone through our program as well, to come back to be an advisory in our program. So this is how we develop our curriculum. So we have a level 1, and it is known as helping ourselves. How do you help yourself? So we talk about treatment and service and getting accurate literacy and to develop communication skills. How to talk to your doctor, your service providers, and other community members. After that, after you have graduated from level 1, and that's a three-day program, and it's 3 Saturdays. After you have finished level 1, we move on to level 2. If you are so interested, you can come back to do level 2, and it's about helping others. So now you have known how to take care of yourself. Go out and see how best you can help others. And it covers peer counseling and support skills as well. Then after you have finished, and that's a 2-day and a 2 full day, and then a retreat component, which is a 2-day retreat. Level 3 is about the community succession planning, where we bring back persons, if they are so interested, to be facilitators. And all our programs through this is facilitated by peers who have gone through the program. So that that's part of our succession planning as well. And all of these programs are run as well with mentors. They are guided by mentors. I think since 2003, we can update that because we just finished a next course. We have done over 200 persons have graduated from the ETSN. And as I said earlier, the different communities that we serve.
So I'm going to talk about an evaluation study that we did recently to look at the long-term impact of our program. So after running it for 15 years, we thought it was really important to capture the important impact and learn from our experiences because we believe that it has made a huge difference to the community, but a lot of times best practices or wise practices in marginalized communities are not recognized and didn't really have the core resource support from the funder. So part of that is actually to share our wise practices and good experiences, but also to really identify ways that we can continue to improve our programs. So we did a mixed method study. We did a structured survey that include 92 of our graduates and focus groups that include 63 of different graduates as well as community stakeholders. And we measure some of the we used the scales on some of the domains that we have identified from a previous research to be relevant areas of change that previous graduates have identified. So that includes health literacy, self-health management, advocacy, treatment adherence, sense of empowerment, social connection and support, community engagement. So each of those have standardized scales that were validated and people fill out the surveys, but we also ask people open-ended questions about what community services have they been engaged in, what volunteer work or paid staff work have they been graduated to since the program. And in the focus groups, we have 5 groups that are for program graduates, including some that are actively engaged in HIV work, some that are not actively engaged in HIV work, as well as 11 of the graduates who have been active as peer facilitators for subsequent rounds of training. And then 1 group for the program mentors and 1 group for partnered organizations, executive directors, and managers. So this is actually, the numbers are wrong, but the proportion actually is correct. So we have the largest proportion of our graduates are ACP population, and then Asians, East Asian and South Asian, and then Hispanic and Latin American. So we're gonna share a little bit of the results, but we wanna get to the some of the reflective learning at the end. How much time do we have? Okay, so in terms of the quantitative surveys, we actually asked people, domains of change from their graduation to the time of the survey, and 93% of the people actually identified that they have improved their health literacy and self-help management advocacy. 76% identify improvement and change in self-care practices. And as you can see, actually, there is like really significant and huge improvement in all of the domains that people felt were important for their change. And especially, I think that over 76% of our graduates reported progressive changes in the roles that they engage in the sector. So many of our graduates went on to become peer support, volunteers, staff for different organizations, as well as researchers, and take on many other roles in the community. So they much went beyond helping themselves. So in terms of the qualitative findings, people really share a lot of very heartfelt, inspirational kind of testaments to some of their experiences in terms of how ETSN helped them build a community, how as newcomers and racialized people, they felt shut down in mainstream organizations and were able to find a comfortable learning space and supportive space to grow and to develop and practice healthcare. And some of our graduates talk about how they were able to use the skills to negotiate their treatment decisions and challenge medical authorities and get access to healthcare, as well as applying to other areas of their lives, such as, I think one of the African Caribbean women talk about how she was able to use that to challenge the school system where her daughters were being mistreated. Right. So it's not just about HIV, it's actually about all aspects of life. So people talk about sense of empowerment, going back to school, pursuing different careers, engaging in research, and becoming leaders in their community. So we want to spend a bit more time on the wise practices and the reflection of why we think that ETSN worked. You want to start? So we summarized it in these 5 main areas.
So, as Alan said, we summarize it in 5 areas. Safe and inclusive learning space that honor PHA lived experience and acknowledge their struggle and affirm their resilience. So one of the things we use, and we believe in it at CAAT, is the G per me per method, because we believe that in order to have our participants attend, they must feel comfortable and they must feel safe. And when it is delivered, when the program is being delivered by their peers, we get better results.
So the other area is a really intentional practice to promote PHA leadership, and as Dale said, greater and meaningful engagement of people living with HIV/AIDS. So some of the examples is that, as we mentioned, all of the program advisory group, majority of the representation are from people with lived experience. And CAAT has actually made a public declaration and commitment that all of our presentations and publications and programs will be led or co-led by people with lived experience. And we've been practicing that since 2007, and we have not missed a bit. So the other thing is we have a structure that graduates from our programs are progressively engaged in increasingly complex roles as leaders, presenters, and facilitators and mentors in the program. So that's a really intentional practice. And I think that one of the sessions we were at yesterday talked about how hard it is to get community participation. But I think we've learned quite a bit of how we can do that.
Right. So response to the training curriculum, and it's grounded in community needs. So the ETSN curriculum is grounded in PHA lived experience, was identified to be effective and responsive to the complex need of PHA and their effective communication.
And then we use an experiential and collaborative learning model. So experiential in the sense that a lot of our training are really interactive and is based on lived experience and scenarios that are constructed by the participants themselves. And collaborative, first of all, we do a lot of group learning, but also we actually have small group projects and homework for people to do in between sessions, between Saturdays, if you can believe. But actually, it helps build community and help people connect outside the training days. So it actually worked to enrich that experience quite a bit.
So the next one is the structured mentorship and community succession, because we do believe in community succession. It's where the participant indicated that the success of ETSN was built on a strong alliance of professionalism, community advocacy, and PHA leadership. We work closely on a structured mentorship and community succession planning.
Yeah, so we actually don't just say like you graduate, then you just, we pass on the work for you to do. We actually continue to work as teams, and we prepare the presentations, and we did rehearsals. We have long debriefing sessions after each training session so that peers can give each other feedback and continue our learning. So in terms of some of the barriers and challenges is, of course, our program is not perfect, but also there's a lot of systemic challenges really in the sector, and beyond that kind of makes it really challenging for racialized and newcomer PHAs. So in terms of the program-specific challenge that, like each of our partner agencies have their own priorities, so sometimes it's hard to depend on people to recruit. And because we can only run the program a couple times a year, so a lot of times we don't have a lot of deployment opportunities for the graduates. And then also systemically, people talk about a lot of professionalization within the sector, and the continued stigma and discrimination for HIV led to the devaluing of PHA's experiences beyond the HIV sector. So people may not be able to take enough pride and get enough access to use the skills and credentials they gain from the training to benefit their career. And actually, one of the alarming and kind of challenging thing that we've identified through the research was that some of the agency directors and EDs actually thought that our peers are overtrained and underused. So they began to question, why do we keep training people if we can use them or we don't have jobs to hire them? So that's actually like a real huge systemic problem. So if we're talking about how we meaningfully engage community, then we need to look at how we put the resources where our principles are supposed to be at. But overall, we thought that we had a really comprehensive and successful health promotion program that combined a lot of elements that are important to the empowerment and well-being facilitation of our communities. And we believe that the lessons we learned are helpful and transferable to many other marginalized communities nationally and internationally. So we just want to acknowledge our graduates, our peer facilitators, our mentors, partnering organizations, funding partners, and our research team members. So thank you very much.
And we do have copies of the report, limited amount, and they're at the table here, so you can get a few of them. Thank you.